Welcome everyone to today's webinar, Trinity Health and the AMA Collaborate in the Fight Against Heart Disease. I am Renee Kuman with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Jennifer Bailey is the Director of Ambulatory Clinical Operations at the Trinity Health System Office, working across many teams to provide clinical support for the implementation of Trinity Health strategies for ambulatory success across the enterprise. Jennifer has been with Trinity Health for 23 years and holds a Master of Science in Nursing with an emphasis on health system management from the University of Detroit, Mercy. Dr. Daniel Weiss Wasser is the Director of Quality and Clinical Informatics for Trinity Health of New England Medical Group and a nationally recognized physician expert in leveraging technology to improve patient care in the primary care ambulatory setting. He joined Trinity Health in 2016 after 12 years of primary care practice, received his medical degree from the University of Massachusetts, and completed a dual residency in internal medicine and pediatrics at Yale. At this time, I am pleased to turn the floor over to James Gilligan, Director of Group Membership at the American Medical Association.
Thanks, Renee. I'm excited to have everyone join us today to learn more about how the AMA and Trinity Health have partnered to help Trinity more effectively tackle hypertension in the ambulatory environment. In a moment, I'm going to introduce our team from the AMA that leads our Map BP program, which really is the foundation of our partnership with Trinity Health. But I do want to use this opportunity to take a moment to say a few words about the new AMA Health System program, which our Map BP program is a part of. This program marks a new strategy for the AMA and how we support large health systems and medical groups and act as a more powerful ally for the physicians who are employed there. The icons you should see on your screen represent just a few areas where we focus our support for AMA Health System partners, whether it be assisting with more effectively identifying and addressing systematic issues that are causing burnout, providing professional development resources, or bringing health system leaders to the table to share their perspective on important issues facing the future of healthcare. Our current partners have already expressed a lot of excitement about our ability to help them advance their groups to the next level. I'll share some ways you can learn more about our new program at the conclusion of our time here today. But I do want to make sure that we move on and talk about a key aspect of our program, which is how we also make sure that our partners are receiving recognition for the ways that they are driving the future of medicine in a positive way. Today is a great opportunity to do that with our partners at Trinity Health. They have really taken great strides to help their patients take better control of their health. So without further ado, I'm excited to introduce Sinead Forkin-Kelly, who is our Clinical Operations Director in Improving Health Outcomes.
Hi, everyone. Thank you so much, Jim. I did want to let our audience know that we're also joined by Dr. Mike Raycotts, the VP of Health Outcomes at the AMA and nationally recognized expert in hypertension control. Please do include any questions that you have in the chat feature. Mike and I will support that question session at the conclusion of our presentation. So before we start, thank you so much to our speakers for agreeing to share their improvement journey with our audience. And listeners, thank you so much for joining us this afternoon. By way of background, the MAP BP Improvement Program is a continuous quality improvement program used to effectively diagnose and manage patients with hypertension. The program is based on the AMA's evidence-based MAP framework. MAP stands for Measure Accurately, Act Rapidly, and Partner with Patients. Our speakers will unpack each component of the program for you today. The program is also the backbone or the QI engine of the Target BP initiative. So MAP is for healthcare leaders and their teams who are seeking to improve health outcomes through a practical, evidence-based approach to care delivery in the ambulatory environment. It is a resource-efficient way for healthcare organizations to improve quality scores and contain costs through a team-based approach. With no external cost to healthcare organizations, MAP can be implemented with minimal impact on visit times and delivers not only rapid but sustained improvement in blood pressure control. The ultimate goal of our program is to reduce the impact of cardiovascular disease and stroke in the U.S. adult population. So at this point, I'd like to hand it over to our speakers to show for us how they have operationalized the program within their institution. Jane, I'd like to hand it over to you.
Thank you very much, Sinead. And on behalf of Dr. Dan Weiss Wasser and I, we are very excited to join all of you today to share our MAP BP program implementation journey across Trinity Health. We'll be sharing this from both a national perspective and a regional perspective. We'd like to begin with a bit of background about who Trinity Health is and who we serve. We operate in 22 states, and we are one of the largest Catholic healthcare systems in America. We, last fiscal year, served 1.6 million individuals via attributed lives with 7,500 employed physicians and clinicians and 28,000 affiliated physicians and clinicians. So certainly an opportunity to have a large impact on quality improvement in hypertension management. Trinity Health's mission drives our vision and strategies. We serve together, and we serve in the spirit of the gospel as a compassionate and transforming healing presence within our communities. We very much are a member of our communities, serving within our core values of reverence, commitment to the poor and underserved, justice, stewardship, and integrity. Our member health strategy really positions us as not only a member of the community, but creating a trusting relationship with each individual we serve as a member of Trinity Health. And we have 5 focus areas in our member health strategy to improve the health of the population or members that we serve. That includes a focus on community health and well-being, creating healthier communities, episodic care, advancing care coordination across our system and care continuum and communities, working with our payer partners and our clinically integrated networks, and managing chronic conditions effectively. We'll be focusing our talk today on effective management of chronic conditions, specifically hypertension, using the MAP BP program. So part of the strategic work that Trinity Health does includes defining priority strategic aims. And for ambulatory chronic condition management, hypertension management is a Trinity Health priority strategic aim, meaning that our entire enterprise across our 22 states is focused on achievement of national improvement across what we call our regional health ministries or our locations within Trinity Health. Hypertension has been identified as an ambulatory strategic aim based on the volume of members impacted and evidence that if we can improve blood pressure management of individuals, we can reduce rates of morbidity and mortality. Trinity Health has collaborated with the AMA to implement the MAP BP program as our framework for this priority strategic aim, with a goal of all of our primary care practices across the nation achieving 80% of members managed to a blood pressure of less than 140 over less than 90. So as we apply that to the Trinity Health MAP, I thought it was very important for you to understand the scope of that work that we're seeking to accomplish. So you can see various locations or regional health ministries and how many patients with a diagnosis of hypertension are currently being served in those ministries by our employed primary care network. On this, the regional health ministries that are green are those Wave 1 and Wave 2 sites that stepped up for that initial pilot rollout. And you'll hear from one of those Wave 1 sites today, Trinity Health of New England. The purple sites are Wave 3. These are sites that we are currently implementing the program in now, and the sites that are in black will be implemented in Wave 4. Digging in a bit further to the scope of this, we trend the number of patients within our employed networks that have a diagnosis of hypertension. And what we have found since we've started this program is we have identified additional patients with hypertension. So I think that's very important to keep in mind that as you start any process improvement activity, you will find more individuals that need that process focus. So currently, Trinity Health has nearly 500,000 individuals across the nation with a diagnosis of hypertension that are being managed by one of our primary care physicians. And this trend graph shows from July of 2018 till December of 2019 how many of those patients are well managed and how many are not controlled. So you can see as we've identified more patients with a diagnosis of hypertension, we've done a great job of managing them, but we also still have pretty consistent opportunity on about 125,000 individuals to improve their management to target. So when we break that down a bit further, we start talking about what matters most to our patients, being very consistent to our mission of improving the health of those that we serve, and looking at a subset of 5 targeted regional health ministries. We pulled their data of the number of patients that have a diagnosis of essential hypertension and how many of those patients are not measured to target. And you can see the breakdown of the specific results that we found. So over 37,000 individuals across 5 regional health ministries not managed to target, which significantly increases the risk of death depending on what that systolic blood pressure range is. So this was very compelling for our providers and our leadership team to say we have a large opportunity to make a meaningful improvement in the lives of those that we serve by focusing on improving hypertension management for the targeted population. So with that, I'd like to turn it over to Dr. Dan Weiss Wasser to walk through what Trinity Health of New England is doing to improve the care and caring for those with hypertension.
Thanks, Jen. Hi, everyone. I'm Dan Weiss Wasser. I'm a med-peds physician by training, and I'm going to spend the next little while speaking to you about our practice's success with the MAP-BP program. So as Jen mentioned, I work at Trinity Health of New England Medical Group. We implemented the MAP-BP program initially in our Springfield, Massachusetts offices, and it's that implementation that I'm going to be focusing on today. We're in Western Massachusetts. We have primary and multi-specialty care across 13 offices. We've been on the EPIC EMR for over 14 years and joined Trinity Health in the summer of 16. We have about 230 providers, about a third of whom are alternative practice providers, and we have about 140,000 active patients. So we're focusing on the ambulatory world here today. This recent article in JAMA Internal Medicine in this past August noted that actually antihypertensive intensification in the hospital setting is associated with poor outcomes without benefits for most patients. So we're not looking to intensify antihypertensive therapy in the inpatient setting. We're just focusing on ambulatory during today's talk. So why do we focus on hypertension as healthcare professionals? So among non-pregnant adults, hypertension is the most common diagnosis used during office encounters, and it's the most common diagnosis that's associated with chronic prescription medications. Despite this, only half of adults have adequate blood pressure control if they have a diagnosis of hypertension, and that's using the most liberal goal of controlling blood pressure to less than 140/90. And in fact, in 2010, high blood pressure was the leading cause of death and disability-adjusted life years worldwide, and hypertension accounts for more cardiovascular deaths than any other modifiable cardiovascular risk disease factor. Those with uncontrolled blood pressure are an important rising risk population, and when we speak of that, we're saying that those with uncontrolled blood pressure are often asymptomatic, as we know, until they have some sort of catastrophic event, which could be a heart attack or a stroke or something along those lines. So when we talk about uncontrolled blood pressure, what do we mean here? So for those without comorbidities, that is, those without established atherosclerotic cardiovascular disease, we use the 2017 American College of Cardiology, American Heart Association categorization, in which normal BP is defined as systolic less than 120 and a diastolic less than 80. We start thinking about elevated blood pressure when the systolic rises into the 120s, and then we're into the range of hypertension with stage 1 and a systolic of 130 to 139, or a diastolic of 80 to 89, and to that more advanced stage 2 hypertension if the systolic is consistently above 140 or the diastolic is above 90. And again, that higher number, that either diastolic or systolic, is the one that determines categorization. I'm recognizing that there are competing and evolving blood pressure goals in the literature, but for the purpose of today's talk, we're going to be focusing on those with established hypertension by these particular guidelines. So how do we diagnose hypertension? So ideally, we're using an average of 2 or more high-quality office blood pressures taken during a couple of office encounters or more, and then we're confirming that with out-of-office blood pressure monitoring done by either home or 24-hour ambulatory blood pressure monitoring when that's available. We use JNC7 from 2004, determining the average of office blood pressure readings greater than 140/90 to be consistent with hypertension, or greater than 130 or 85/85 consistent when using daytime out-of-office blood pressure. In 2013, JNC8, the latest JNC work, did not define hypertension, but instead was more focused on treatment goals. And then in 2017, ACC/AHA came out with a guideline in which the average of in-office blood pressure readings greater than 130 or over 80 were felt to be consistent with hypertension, as I referred to in that previous slide. So let's look briefly at the 2017 ACC/AHA thresholds and treatment recommendations. So all of these recommendations recommend that lifestyle changes are advised, even for those of us with normal blood pressure. Optimal lifestyle habits are key, certainly. And then for those with stage 1 hypertension with ASCVD, atherosclerotic cardiovascular disease, or a 10-year cardiovascular disease risk of greater than 10%, or any of those with stage 2 hypertension, pharmacotherapy is advised. And indeed, excuse me. I'm sorry, one moment here. Right, so in the way that we determine on a population health level the blood pressure goals at Trinity Health, the nation's second largest Catholic health organization, is by looking at a denominator that it consists of the number of patients with hypertension who are in the age 18 to 85 range. And the numerator is those whose blood pressure is adequately controlled during the previous 12 months, as represented by the most recent blood pressure at an office encounter, that is a blood pressure of less than 140/90. And this is the National Quality the National Quality Forum's Measure 18, also known as NQF 18. This is also used by the Center for Medicaid Services. And Trinity's priority strategic aim, as Jen had alluded to, is top decile performance. That top decile performance consists of a control rate of 80% or greater. So this is really the slide that demonstrates how Trinity Health of New England did with the MAP-BP program. We implemented this program in November of 2018 and had a rate at that time of about 72%. And in short order, we were able to exceed that top decile performance rate of 80% in about 6 months. And over the course of about a year, we improved our blood pressure control rate by about 12%, up to about 84%, which is about where we remain to this day. We were able to achieve this through a program that was alluded to at the top of this presentation, and that I'm going to be speaking about for much of the rest of my presentation here, the MAP-BP program. And again, as previously alluded to, the MAP-BP program consists of 3 steps. The first step being measuring accurately, that is obtaining accurate representative blood pressure readings. Acting rapidly, which is implementing evidence-based protocols for managing hypertension, reducing what is so-called clinical inertia, which I'll be speaking about. And then third, partnering with patients, engaging patients in healthy lifestyles and self-management for their own blood pressure control. So let's dive into some of this in some greater detail. So this first step in the program, the Measuring Accurately program, is focusing on the actors throughout the practice. And when I speak about the actors throughout the practice, I'm talking about not just providers, not just clinical staff, but also biomedical engineers, facilities professionals, IT resources, etc. So for example here, number 2, we engaged our biomedical engineers to calibrate the sphygmomanometers, the blood pressure cuffs, throughout the practice to make sure that they are accurate, make sure they are reliable, so the providers could feel more confident in making their treatment decisions. We recruited facility staff to reconfigure our exam rooms. Staff, providers, patients alike were all engaged and informed about proper techniques for measuring blood pressure and to encourage those techniques, and when needed, to provide training. As noted here in number 4, we have utilized our IT staff who work, again, consistently in the EPIC EMR to use that EMR to identify gaps or opportunities in the blood pressure measurement process, and using various reports that I'll speak about in some greater detail. And finally, using our rooming staff to leverage technological advances in blood pressure advancement to make sure that we are measuring blood pressures as accurately as possible. AOBP is the device that we have been using for this. AOBP stands for Automated Office Blood Pressure, and this device allows blood pressures to be assessed several times in a single setting while unattended, so that this minimizes white coat hypertension, which is blood pressure that's elevated in the medical setting, as well as masked hypertension, which is readings that are lower in the office than in the home setting. So this is the AOBP device that we use in our practice. This is the Omron Heme 907 XL. This is the same device that was used in the 2015 Sprint trial. This is not the only AOBP device that's available on the market. There's also a Welch Allyn ProBP 2400, which actually costs somewhat less and is also frequently used by a number of practices. So the goal here is to measure an average 3 unattended blood pressure readings over 5 minutes. So in my practice, if an additional blood pressure reading is elevated, that is the systolic is 140 or greater, or the diastolic is 90 or greater, the staff are encouraged to via protocol to apply that AOBP to the patient, regardless of whether the patient actually has a hypertension diagnosis or not. We don't want to slow the staff down, asking them to delve into the medical record to determine whether the patient has that diagnosis. The medical staff person then leaves the room and affixes a magnetic egg timer set to 5 minutes to the metal frame outside of the exam room door. And during that following 5 minutes, the AOBP automatically assesses the patient's blood pressure 3 times and presents an average of the 3 readings, which the nurse then records. And this is really an effective way for getting a good blood pressure reading. In fact, Handler et al. In the Journal of Clinical Hypertension in October of 2012 demonstrated that those with an initial reading of 140 to 159 over 90 to 99 on initial reading were found to be less than 140 over 90 when 3 subsequent readings were measured, again in 35% of the cases. Whereas when an initial reading was in the normal, so-called normal range, less than 140 over 90 on first reading, and 3 subsequent readings were averaged, the subsequent reading were found to be still less than 140 over 90 in over 97% of the cases. I'm sorry, it looks like I'm being asked to hang up and call back in. I'm sorry, I will call right back in.
Hey, Dan,
Dr.
I think we
Weiss
can
Wasser?
hear you okay.
Yeah, we can hear you just fine. Perhaps until Dr. Weiss Wasser gets back on the line, we can answer some of the questions we have here in our chat. And thank you, audience members, for submitting those. Maybe to get us started, we can ask Dr. Raykotz a question. So Dr. Raycotts, when we introduced the program, we indicated that it was an evidence-based program, and we indicated that some results have shown that the program is sustainable over time. Can you give us, the audience, a little bit more detail about how we have identified the sustainability of the program?
Sure. Each of the three components of the program, measuring blood pressure accurately, acting rapidly to treat uncontrolled high blood pressure, and partnering with patients, has a set of standardized evidence-based protocols that can be audited or use competencies by the primary care clinical team in practice settings. So that really helps teams over time make sure that they continue to implement accurate, reliable processes to improve outcomes. So that's one way. We've also created, and I think Dan's going to talk about that in a few minutes, a set of process measures that can be and performance measures that can be tracked over time that can assure that each of the practice settings can be monitored to make sure that they're improving their processes and tracking towards improved outcomes. And if it's sort of like an early warning system, if a clinical team, for example, 6 to 12 months later, starts to fall off a little bit on their measure for measuring blood pressure accurately, we can intervene, the practice can intervene early to make sure that they do some competency testing and get those protocols back up to speed in real time in the real world. So it's a very practical program in that way, using a very simple set of measures to drive improvement.
Thank you, Dr. Raycotts. Very informative. And perhaps we'll take just one more question in the hopes that Dr. Weiss Wasser will be able to join us again. We get this question a lot as we travel across the country, and I'm hoping that you can give some guidance to our audience here, Dr. Raycotts. So the question is from one of our audience members: how do you gain buy-in from providers to engage them in the MAP-BP improvement program? Jane illustrated a lot of data that they shared at Trinity Health, and I'm sure that those data are drivers for engagement. But do you have any other guidance that you could give to the audience on this topic?
Well, I think there's a couple things that really helps a lot.
I'm so sorry.
Oh, hi. Go ahead, Dan.
Welcome back, Dan.
Yes, I'm so sorry about that. I don't know what happened there.
Dr. Raycotts, to answer the question, or do you want to just get right back into your content?
That's up to you.
Oh, yeah, just take it away.
Okay. So I believe that I spoke about the office automated blood pressure and how that process was used in our practice. We also use in our practice these posters, which are put in all of our adult medicine exam rooms. So even if you decide not to proceed with the program, using this free poster can really help with staff, provider, and patient awareness about blood pressure technique. And I really derive some degree of pleasure when I hear that our patients insist on using their insist that their specialists, who they see after having been seen in our primary care office, use proper blood pressure techniques that they've learned in their PCP's office as a result of this poster. And we also show this poster on digital waiting room displays in our offices. So this is what a typical exam room looks like in our practice. We really found that each exam room was unique and found it a challenge to place the cuff near a chair and something that could support the arm while also allowing for visualization of the poster. So here you can see the poster that we previously showed on the previous slide. And then patients are seated in a chair that allows for their feet and backs to be supported, and that allows them to see the poster and allows them to place their arm on an exam table so that the reading can be taken while their arm is supported at heart level. And then ideally this this sphygmomanometer would ultimately be, this dial would be moved lower to make for a more ergonomic experience for the rooming staff. So in terms of this implementation of the AOBP, we wanted to ensure that every patient with an SBP of greater than 140, equal to or greater than 140, or a diastolic of greater than or equal to 90 could be measured while minimizing any impact on patient flow. So we purchased enough devices to encourage that they would be used consistently, and that was to provide one device for use by every 2 providers. And then as we recorded these readings, we documented this in Epic using a homegrown flagging process to denote when a blood pressure reading was a confirmatory one. And then we were able to thus report on staff utilization of the AOBP with a confirmatory blood pressure report, and staff supervisors would use this report to perform targeted outreach to rooming staff. And as you can see, our confirmatory blood pressure rates increased quite a bit right around that July or August 2019 timeframe when we started to use this confirmatory blood pressure report. The second step in the MAP-BP program is this acting rapidly step. This focuses really on provider behavior. So when we use this step, we used an easy-to-use, low-cost, evidence-based treatment algorithm embedded within our EPIC EHR to drive proper prescription use for managing uncontrolled hypertension. So we started with a fixed-dose generic combination and then increased as needed. So this fixed-dose combination was an angiotensin converter enzyme inhibitor calcium channel blocker combination, as found to be more effective in 2018's ACCOMPLISH trial. And we have found that lower doses of two medications are more effective and result in fewer withdrawals than a higher single-dose therapy, and this was confirmed as recently as September in Salam et al.'s article in the Journal of Hypertension. We then, if needed, add a long-acting, low-cost thiazide diuretic, indapamide, and then maximize this dose if needed. Indapamide is more effective than the short-acting hydrochlorothiazide thiazide diuretic and less expensive than long-acting thiazide diuretic chlorthalidone. If patients' blood pressures remain uncontrolled, we then add the potassium-sparing diuretic spironolactone. If patients remain on the spironolactone and are compliant with all of these medications, we can then consider them treatment-resistant and often refer them to a specialist. Oftentimes in our practice, this is to our no-cost pharmacist-led hypertension clinic. Medication titration has great proven benefit as compared to other interventions, reducing morbidity from hypertension. In fact, for those with stage 2 hypertension, aged 18 to 75, antihypertensive pharmacotherapy leads to a 50% relative risk reduction in heart failure, a 30 to 40% risk reduction in stroke, and a 20 to 25% risk reduction in myocardial infarction. And this is the article I spoke about a moment ago from Salam et al. This indicates that dual combination therapy improves blood pressure control by a third, increasing it from 48 to 65% without withdrawals from adverse effects. Another aspect of our Act Rapidly protocol in which we engage our clinical teams involves uncontrolled hypertensive work lists. Again, leveraging our IT resources, we ask staff during clinical downtime to outreach to patients within their own clinic, and the staff can then see these lists shrink over time as more and more patients come under control. We've also established medical assistant staff follow-up clinics in which providers can make medication changes, provide clear steps, and arrange for no-cost, easy-to-schedule follow-up with our medical assistants. These medical assistants then provide further assessments of barriers and compliance with patients and also give them some additional education. And then the patients are returned by the MAs to the primary care teams for further follow-up. On step 3, the partnering with patients step, we then focus on the patient's role in this entire process. We're educating patients regarding the impact of their lifestyle on blood pressure and empowering patients to take more ownership of their own blood pressure by doing monitoring at home, and they can note the impact of their lifestyle and their medication on their blood pressure readings. We've also implemented a self-measured blood pressure device loaner program, and all of these steps have been accomplished through the previously mentioned medical staff follow-up clinics. We're also looking to take advantage of newer reimbursement for quality measure recognition of home blood pressure management. So here are these new codes that are new for January 2020 from CMS, CPT code 99473, in which there's reimbursement for staff in providing training, device setup, and calibration of SMBP devices, and then CPT code 99474, in which providers can be provided with once-a-month reimbursement for ongoing treatment decisions provided outside of a regular E&M visit. AMA and American Heart Association provide excellent free resources that are available at targetbp.org that help patients to understand the consequences of uncontrolled blood pressure as well as the effects of their lifestyle on that blood pressure. And as I mentioned, we've been developing this SMBP, the self-monitor blood pressure device loaner program for patients who can't or won't buy their own devices. Our MAs teach patients about proper measurement technique and the impact of their lifestyle. And these devices are not costly. Even if they include Bluetooth technology, they're only about $40. And this Bluetooth technology allows readings to be uploaded to devices like a smartphone, makes it so the blood pressure readings can be more easily shared with a practice, and averages and trends can be determined. AMA also provides excellent documentation so that patients can be instructed about how to log their blood pressures. These sheets recommend taking 2 measures twice daily for a week, and if these readings aren't uploaded, such as through a device with a Bluetooth connector, they can be entered into an in-office blood pressure average calculator, which can be found at the AMA's website, again allowing for recording of a average blood pressure reading. So in summary, the benefits of the AMA's MAP-BP framework: this framework can be applied to drive improvement throughout the practice, engaging so many members within the practice as well as patients. It's a program that is evidence-based, proven to be successful for us and other practices, structured yet flexible for us, using existing functionality within our own EMR and existing staff within our practice. AMA has been a wonderful partner in this, able to train providers and clinical teams at no charge to our groups, and no additional hires were required at our practice. So it's really been a wonderful program in that respect. As an impact of this program, we've been able to achieve this gold status recognition from the AMA and the AHA. We were able to achieve blood pressure control rate, of course, far greater than 70%. This is the current highest level of recognition that AMA, AHA have, but they're pursuing more aggressive levels of recognition. And this has also allowed us as a practice to obtain some recognition within local media, which was encouraging. Well, the plan now is to spread the MAP-BP program throughout the rest of Trinity Health of New England, from Springfield, Massachusetts, to the rest of New England into Hartford and Waterbury, Connecticut, and then from there to spread it across all of Trinity Health, from the East Coast to the West Coast, and from Maine all the way down to Florida. So with that plan for spreading things nationally, I pass the reins back over to Jen Bailey, who can hopefully speak in greater detail about this national effort. Thank you, Jen.
Thank you very much, Dr. Weiss Wasser. We really appreciate you sharing your journey and being one of the first in Trinity Health to implement this program, and we celebrate the success that you and your teams have had in that. So as Dr. Weiss Wasser reviewed the program, the 3 components, again, measuring accurately, acting rapidly, and partnering with patients, Trinity Health identified that this program would be perfect for us to replicate across the nation with the standard tools and resources for our ambulatory provider practices. So we really took the learnings from our pilot sites for the Wave 1 implementation, which not only included Trinity Health of New England, but also Loyola University Medical Center in Chicago, Illinois, and Holy Cross Health Network in Montgomery, Maryland. We took those learnings and then designed a program to create awareness, engagement, educate, and implement this program across the Trinity Nation. So Trinity Health started with a MAP-BP program outline. What are the pre-implementation program activities that we need to undertake to be successful? And I want to highlight that that is inclusive of identifying executive sponsor support and physician champions to move this program forward. So the Trinity Health team includes members at our national system office, as well as each regional ministry that are accountable for adoption of this program, as well as improvement activities with the program. We've determined the members of a multidisciplinary regional team, truly engaging everyone that comes in contact with patients in our ambulatory clinics in this improvement process. Training those teams along with our partners at the AMA and using their standardized tools and materials so we can make sure that there is evidence-based clinical consistency in the work that we're doing. working on implementing the program, just as Dr. Weiss Wasser laid that out within our practices. Do we have the proper devices, exam room configuration, training, and performance monitoring to measure accurately? Do our providers have the evidence-based guidelines and tools they need to implement, act rapidly for their patients? And are we partnering with our patients to really engage in improvement in their health and self-management? And then we monitor our activities with implementation as well as process improvement across the medical group level. So we have set up a framework of monthly calls with each of our sites to monitor their performance, as well as an affinity call every month with all of our sites together to spend some time on engagement and education, some sharing of best practices, as well as barrier resolution. So to do this, we follow the Trinity Health leadership system structure. This is our process improvement engine, and it is built to empower all of our colleagues to continuously improve those priority strategic aims. So hypertension in this case. We ensure clarity of purpose. We've spent a lot of time across Trinity giving the message about why hypertension management is important to the organization, the communities we serve, the individuals that we serve, and we continue to repeat that message. We align that message with a plan using data as well as the implementation of the program to drive performance improvement. And we respect the culture. We respect that healthcare delivery is unique to the communities that are served and unique to the individuals that are served. So we really seek to understand what is happening at the practice level in the exam room and what types of tools and resources are available and necessary to drive that improvement. So the next two slides, I certainly am not going to read all this to you, but I thought it would be very helpful to you as attendees to really see what that step-by-step engagement looks like using our Trinity Health Strategic Leadership System for implementation, engaging all of those that have a piece of this process improvement work, planning together, implementing, and then supporting that implementation across the continuum, and then implementing the tools that are provided by the AMA, as well as tools that we create internally to help with our clinical, operation, and documentation workflows. We also take into consideration that culture is just as important as strategy, maybe even more. So we make sure that we engage the entire team, head, heart, and hand in the adoption of this program. So for the head, making sure that we are reviewing that data and making the case for change, that this is one of the most common diagnoses in primary care, as Dr. Weiss Wasser mentioned, that this is the #1 modifiable risk factor for coronary artery disease and cardiovascular disease, and that we have variation in performance. And for all of you in quality improvement, we know that variation is evil, and we like to eliminate that. Engaging with the heart, and we're telling patient stories, what matters most. How can we make improvements so we can improve the lives of those that we serve? How do we avoid preventable disease and harm for our patients? And we align that with our mission and vision to continue to be that member-centered healthcare organization. And then with the hand, how do we operationalize this program and implement evidence-based approaches to improve hypertension management, deploying standard workflow? So this is an example of the support tools that Trinity Health has created and has available nationally to all of our providers to readily access. This includes the AMA Map BP program content, content on education and training, workflows that have been developed across all of our regional health ministries, Trinity standards for care for hypertension management, tools that have been developed to aid ministry implementation. So we work very hard not to reinvent the wheel and to share best practices and tools, research articles, and as those articles and evidence become published, we update this continuously, and then a ever-evolving FAQ document. As questions come up, we work hand in hand with the AMA team to answer those questions, and then we publish those so that they are available for all of us to learn from. So a full set of AMA tools can be accessed at the AMA site, but also our Trinity Health team can access our own internal toolkit. I do want to cover briefly the importance of including supply chain and clinical engineering in this work. Of course, measuring accurately, a large component of this work includes making sure we have appropriate validated blood pressure measurement tools, such as the AOBP device. So we work as an organization with our supply chain leadership management to offer devices that are validated and recommended by our American Medical Association partners for purchase within our clinics. We also work with our clinical engineering office so that they're aware when these devices are ordered and they can expect for them to come. They work on the validation and maintenance of those devices, putting in a standard process for training of the staff as well. So we have standard Trinity Health process across the nation now that includes ordering preferred devices as well as training on and maintaining those devices so that our providers and clinical care teams can be assured that they will have the equipment that they need to be successful in this work. We no longer support the use of manual handheld blood pressure devices across Trinity Health due to the inconsistency with the accuracy of those devices. So briefly, some lessons learned across those initial pilot sites, those Wave 1 sites. First and foremost, this is a team effort, and this program really has helped us with the team-based care strategy of every individual in that practice has a piece of this work, from patient identification and outreach to rooming the patient and taking that accurate blood pressure management, to the clinical workflow of getting that information to the provider so that they may act rapidly, to providing that patient with education and resources so that they can manage their health and their blood pressure effectively. We engage system support, again, on device purchasing, maintenance, room configuration. We invest in the resources and infrastructure for this program, including AOBPs, so that a shortage is not a barrier to taking an accurate blood pressure, but also including the time it takes to educate and re-engineer our workflows from a clinical and documentation perspective. Communication and training are clinical and must be invested into this process, so we do allow for time for the system office team to be able and to go out and train the staff and be available to answer questions. We do have a medication algorithm available, and note that there's not one perfect order set, but where there's strong clinical evidence, we'd like to standardize practice as much as possible. Inform continuous improvement, and work on individual site and provider improvement where we need to, and following up on behavior consistently. Our focus for 2020, this really is our focus plan for success, to implement the MAP-BP pilot in all of our RHM locations, to continue to support Wave 1 and Wave 3 spread of MAP-BP, to work with those groups on a monthly basis to support ongoing implementation. We have included appropriate device purchasing within our budget guidance. We are standardizing documentation and clinical workflows. We work with ambulatory facilities design, and you can see on this picture what one of our standard exam rooms look like now to ensure that we have accurate patient positioning for blood pressure monitoring. We have moved all of our new facility design to include an AOBP in every one of our rooms. And then, of course, we rely on our leadership system principles to support successful implementation. So that wraps up an overview of our regional and national strategy. So at this time, I'd like to turn it back to Sinead.
Great, thank you. Thank you so much, Jen. So we do have several questions that we're going to get to. I assure the audience that should we not be able to address all the questions in the chat today, we will follow up with you after we conclude the presentation. So please continue to enter any questions that you may have. Before we go there, thank you so much, Dr. Weiss Wasser, for really being so specific in the step-by-step methodology you use to implement the program at your organization. I am confident that our listeners would find value there. And Jane, thank you so much for digging really deep in some of the operational stability tactics that you have implemented across your huge geographic footprint. We understand that that is a large body of work, and so wanted to compliment you on that. So to turn to our questions here, we do have a question from the audience, and actually Dr. Weiss Wasser touched on this, but just to be very specific, I'm going to field this question to Dr. Raykotz, if that's okay. The question reads, are there any recommendations of a device that can be used at home for monitoring blood pressure, or can this be used to augment the program with the care provider? This, I assume, meaning home blood pressure monitoring or self-blood pressure monitoring. So Dr. Raykotz, can you take that?
Yeah, sure. It's a great question, and it's one that it's probably one of the most common, if not the most common questions that we get. I think there may be a bit of a misconception that all blood pressure measurement devices that are sold in the United States have been validated for clinical accuracy, and unfortunately a majority of them have actually been not. So it's very important that when recommending self-measured blood pressure devices or use of automated office or semi-automated devices in the clinical setting, that you use a device that has actually been validated for clinical accuracy, having been tested using a clinical validation protocol. So just, we can make available more information to you about which devices have and have not been validated, but I'll just say very briefly that most countries throughout the world now are starting to have either a European device list, or this is true in Asia, Australia, and even now in North America and Canada, a place where you can go on the web to look up which devices have been through validated protocol testing to make sure that they're accurate. In the United States, to this point, we haven't had one, but the AMA has been working very hard with a team of national experts, and later in the spring we'll be launching the U.S. validated device list, so that whether you're a health system, a primary care physician, a specialty physician, or a person who's in the community, you can look up devices that are validated for clinical accuracy at home. The second part of that question, can we incorporate self-measured blood pressure devices into this program? There's a very strong, one of the strongest in the country, programs on how to use self-measured blood pressure monitoring to impact clinical care for patients. And I'll leave it at that. We can address any requests in the emails that are given at the end of the presentation to send you more information.
Great, thank you so much for addressing that. Dr. Raykotz, I'm actually going to field this question towards you as well. Dr. Weiss Wasser spoke about integrating their standard treatment protocols into their EHR. The question reads, have you been able to standardize treatment protocols? If so, how? So maybe you can give some specifics as to other strategies you've seen as we've partnered with healthcare organizations across the country. And for those who might not be able to do that, can you shed any light on some of the barriers that we have identified so that the audience may anticipate them should they experience them?
Sure. Well, it's widely recognized that therapeutic inertia, as Dan mentioned, the failure to initiate or intensify therapy when indicated for people with uncontrolled high blood pressure, that inertia is the leading cause of uncontrolled high blood pressure in the United States and really most likely around the world. So having a protocol to use for the entire team has been shown again and again to be extremely effective in combating therapeutic inertia and it's something that we highly recommend be implemented across the system for all members of the care team. So just having a treatment protocol, some people call them treatment algorithms, can be helpful. What Trinity has done and what Dan specifically has talked about doing is taking a standardized treatment protocol and converting it to an order set in their electronic health record that makes it very easy to get good recommendations that are right there in front of you very quickly for not only the recommended of drug classes and combinations of drug classes that are effective for the patient, but to include dosing and escalation of dosing. So, Dan, I'm not sure if you want to chime in here, but this is one of the things that was really impressive about how you implemented the program at Trinity.
Well, thanks, Mike. Yeah, we're really proud of the work we've done. We couldn't have done it without you and the support of others. I would just say that, as I believe Jen alluded to, there is not one way that this can be done. This is a way, and a way that is evidence-based and cost-sensitive. But certainly we're not trying to advocate cookbook medicine. We understand that some providers have their own ways of doing things, and we just want to make sure that we are advocating a way that makes it easy for providers to pursue algorithms that are proven and cost-effective for our patients. But yes, we found that implementing this within the EHR is a really effective way of making it easier for our patients. Thank you.
Thank you so much, Dr. Weiss Wasser. Okay, so I think that we have time for just one more question. Again, if you have any other questions and want to document those, we will follow up with you after the event today. The last question, really any of our speakers can take, or I invite Dr. Raycotts to also chime in on. The question is each of your providers aware of the other's performance? And if so, has that generated any healthy competition within your practice that has resulted in improved control rates over time? Maybe, Mike, would you like to start? And then I'm sure both Jen and Dan probably have experience here.
Well, I can just say that this was famously done by Kaiser Permanente in Northern and Southern California using monthly reports of healthcare site performance in blood pressure control to sort of create an air of competition amongst the sites themselves, which was extremely effective. And then this is another great way to get people, healthcare providers and clinical teams really excited about improving blood pressure control. But why don't I turn it over to Dan and Jen to see if specifically they have any suggestions.
This is
Mike,
Dan.
this is Jen. Oh.
Go ahead, Jen.
Go ahead, Dan.
So I would just say that this is something that is often a source of controversy. Providers obviously like to do well, are used to being at the head of the class, but some providers don't like to be unblinded in this sense, feel like their patient population is in some way more challenging than other providers' populations may be. So in our practice, we've sort of taken a bit more of a top-down approach and have unblinded these results to our leadership, who then work with individual providers. But I certainly think there's an opportunity down the road for pursuing that Kaiser Permanente approach that Mike outlined. Jen, do you have anything you would add?
Yes, thank you. So I think from the Trinity Health System office standpoint, it's important to note that we publish a monthly report for performance by regional health ministry for all of our priority strategic aims. So all of our groups know how each entity is performing across the board on hypertension management, for instance. And when we are working with our pilot site offices on their monthly calls, they see an unblinded report of the pilot practices within their region, how they are performing with hypertension management. We do rely on those pilot practices then to do the breakdown by provider within the practice on their provider performance, but we do have this unblinded at the organizational level as well as at the practice level, and we review that data monthly.
Thank you so much, Jen. So to say that it's been a pleasure to partner with the Trinity Health team is a complete understatement. On behalf of the AMA and the Improving Health Outcomes team, we look forward to strengthening our relationship in the future. And thank you so much for the opportunity to partner with you. That said, I'd like to turn it back to Jim for closing remarks.
Thanks, Sinead. one of the things we're excited to be able to do at the AMA is for everybody to learn how to move medicine and drive the future of medicine by sharing the successes that our partners have had. And what a great opportunity today to learn from the team at Trinity Health on how they've been able to reach higher levels of hypertension control. I definitely encourage you to reach out to Trinity Health. Their contact information you should see on your screen if you have any questions specific to the work they've done. Great opportunity to learn how to not only improve it in one practice location, but then to be able to spread it across an entire health system. If you're interested in learning how you can use Map BP program at your own practice location or health system, please feel free to reach out to either Dr. Raycotts or Sinead. We've worked with a number of health systems and healthcare organizations, and one thing we've learned is that every group is different. Every group has different needs, and so a quick discovery call, we can see if maybe we can have the same success with you as we've had with Trinity Health. And then finally, if you're interested to learn more about the AMA Health System Program and other ways we can put the spotlight on the great work you're doing or help you look into things like burnout and professional development, my information is on the right-hand side of your screen. I'd be happy to set up another quick discovery call with you as well. Keep an eye out from our team. We're going to send an email with this information, so if you do have any follow-up, you'll know how to find us, and we hope you have a great rest of your day. Renee, I know from Becker's you have a couple of last notes.
Thanks so much, Jim. That is all the time we have for today. I want to thank Jennifer and Dr. Weiss Wasser for their excellent presentation and the American Medical Association for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.